So, Dr. Nuraini, are you ready? Mr. Pradeep, are you ready? Can we start?
Yes, yes.
So, good afternoon, everyone. Welcome to weekly webinar organized by College of Physicians Malaysia. We are now in the fourth week of Rheumatology month. Our topic for today is approach to joint pain. Our speaker for today is Dr. Pradeep, rheumatologist from Hospital Seri Manjung, and our chairperson is Dr. Noraini Ibn Hussein, consultant rheumatologist from Hospital Raja Permaisuri Bainul Ipoh. She's a dedicated and motivated doctor and has great interest in the field of rheumatology. She has published many articles both local and internationally. Besides that, she loves teaching medical students, junior doctors as well, trainees. Without further ado, let's welcome our chairperson, Dr. Noraini.
I'm trying to find a button. Okay. All right. Good afternoon thank you, Priscilla, and good afternoon to everybody who is actually joining online for this very interesting topic, approach to joint pain. I am a consultant rheumatologist from HRPB. I'll be chairing this session. Before I pass over to Dr. Pradeep, I will introduce him roughly. I know him very well. Okay. When I was training, he was still an NMO in Hospital Sri Manjung. Very dedicated person, interested in rheumato for a very long time, and finally he is a rheumatologist himself, and in fact, quite advanced than me. You know, see, he has got a lot of things, a lot of qualifications behind him. He graduated from Manipal Academy of Higher Education of Malaysia. Subsequently, underwent a training in few hospitals in Malaysia, and finally managed to attain his MRCP, and went on to do his fellowship in rheumatology, and be gazetted as rheumatologist for about 2 years or so, Pradeep, I think. And he's very active in educating himself and obtaining a lot of things behind him under his name, to actually empower himself to continue teaching not only the fellow colleagues but also medical officers and audience. I mean, and general public. You know, in terms in either in the field of rheumatology or internal medicine. Without further ado, I shall welcome Pradeep to carry on with the session. Pradeep, are you there?
Someone muted me. Can you hear me now?
Okay. Yep.
Okay. Is my slide seen now?
We can't see your slides though.
No, doctor.
Wait, sorry. Let me reshare this.
Okay,
Okay.
see.
You can see it now?
Can see.
Can I?
Yep.
Yes.
Okay. All right. Sorry for the technical problems. Okay. Right. Okay. Welcome everyone to today's webinar session, the last of the rheumatology series for this month and for this year. So I will be covering on approach to inflammatory arthritis, which I thought was very important because I think a lot of medical officers or medical physicians would see these patients first before referring to us in rheumatology. So in the next 45 minutes, I plan to walk you through recognizing, assessing, managing inflammatory arthritis in basically in a real world situation. So I'll try to keep it as practical as I can, and hopefully what you learn today you can apply tomorrow in your clinics Okay, feel free to ask questions in the Zoom chat. I can't really see much of the audience. I prepared some questions, but we shall see as we go along. Okay, these are my disclosures. So these are some learning objectives that I've highlighted for today. So by the end of today's session, I hope that you'll be able to define inflammatory arthritis and differentiate it from non-inflammatory arthritis. You should be able to recognize red flag presentations that require immediate intervention. I hope that I'm able to impart to you how to use a structured approach in history taking and examining the patient, and learn how to order and interpret appropriate laboratory and imaging investigations. I think what happens is everyone tends to over order, and it becomes very, very complicated later when something turns out to be positive, but it's not very practical or not very focused to the patient. I would also hope that you will be able to learn how to apply the classification criteria and see whether it's useful or not for your patient, and ultimately outline the management principles that you could use in your patient. So just to open up the topic, I'd just like you to see this chart. This chart is a big chart. Arthritis is actually a very big topic. You've got so many components to it. You've got an autoimmune component, there's a degenerative component. So it's not just so straightforward, but generally, I think at the end of this talk, you should be able to differentiate between inflammatory, which is more towards rheumatology, and non-inflammatory causes, which you may need your orthopedic or orthopod colleagues to come in and help us, right? So the burden of musculoskeletal disease in the country is quite vast. If you look at data from primary healthcare, 1 in 5 patients that come to the clinic kesihatan in our country are actually due to musculoskeletal problems. And joint pain is one of the commonest forms of referrals to rheumatology. So it's a big thing, and I think all of us should learn how to approach these kind of cases. So I'm going to do some basic pathophysiology, some definitions first before I really go into the main topic. To simplify things, when you call or you look at a patient and you say there's arthritis, you should have pain and swelling. It's a very simple thing. And this pain and swelling, there should be cardinal signs of inflammation in these patients, where there should be some swelling, there should be some joint, it should be a bit warm, there may be redness, there may be pain, and there's loss of function, meaning there's restriction in the movement of the joint. All 5 cardinal signs need to be there, not necessarily, but technically some of it should be present in the patient. When we say arthralgia, it just means or refers to pain in the joint. Okay, there should not be any swelling involved. Okay, when a person comes to you complaining of joint pain, I think very quickly you need to identify whether the pain is articular or is it extra-articular or peri-articular. So very quickly, a simple test is to look and see whether pain can be elicited with gentle passive range of motion of that joint. If it is, then it's articular. If it's not, it's most probably extra-articular. I'm going to run very fast because I got quite a number of slides and I want to teach you all how to look at X-rays and some pertinent imaging. Okay, so this is just some basic theory that I wanted to run through with you all. So what exactly is inflammatory arthritis? So what it means is basically you consider inflammatory arthritis where you are able to show there's persistent joint inflammation. And in our case, it's generally immune mediated, okay? They will come with pain, swelling, there may be some joint warmness, and very often we find they come with early morning stiffness. And the cutoff that we usually use is 30 minutes, okay? It's very important to differentiate this from non-inflammatory causes, basically mechanical causes, and you do find those patients having activity-related pain, meaning the more they use the joint, the more painful it becomes. The stiffness may not be so pronounced. Usually it does not hit 30 minutes. Often they are 15 minutes, say in the cases of osteoarthritis. But yes, there are some cases that may extend up to 30 minutes. But key differentiating point is the early morning stiffness. That's very prevalent in an inflammatory arthritis patient. And if it's activity related, it's more of non-mechanical, right? So some red flags which I think you all should know, okay, whenever a person comes with an acute hot swollen joint, monoarthritis, I think the first thing that should come into your mind is to rule out septic arthritis first. Okay, especially if it's an acute presentation. Other situations is like a patient that has rapidly progressive polyarthritis. You may want to think of a very aggressive form of rheumatoid arthritis. This patient may require an early referral. Okay, if you do encounter patients that have very severe pain with systemic symptoms, you may want to think of other more rarer causes, malignancy, sarcoidosis, a bit more complex conditions. What about patients that present with new neurological symptoms, especially when there's bowel and bladder involvement? Please think of spinal cord pathologies and don't jump straight to inflammatory arthritis. These are red flags that need to be attended as fast as possible and involve the relevant parties. Okay. Right. So how do we approach these patients? So I have tried to simplify it and I've come up with 8 steps. Okay. So I will go through one by one. Basically, you're going to look at a patient that comes in with joint pain, look at the duration and onset of the symptoms, assess the distribution and joints involved, determine whether the nature is inflammatory or not. After getting this information, you're going to examine this patient. After examining the patients, you are going to look for extra-articular manifestations, look and see whether this patient has any associated medical illnesses which are related, ask them for significant family history, and look at their past medical history. Look and get a relevant drug history. So I'll run through quickly. So onset and duration should come hand in hand. So if you look at the onset and it's abrupt, you have to think of things which are a bit more acute, such as whether there's an acute trauma, whether it's a crystal arthropathy like gout, pseudo-gout, or whether there's an infection going on in your patient. If it's something a bit more gradual, then perhaps it is something truly rheumatological in nature, perhaps rheumatoid arthritis, psoriatic arthritis, or perhaps just simple osteoarthritis. Regarding duration, you have acute and chronic. The cutoff we take is usually 6 weeks. Of course, some people do take hyperacute, as in 2 weeks. A gray area is 2 to 6, and then chronicity usually is 6 weeks. But there are some people who even take a cutoff of 3 months for chronicity. So acute conditions, I cannot stress more about septic arthritis. You need to think of that. Think of trauma, think of crystal arthropathies. Chronicity, again, more towards rheumatoid. So we have our rheumatoid arthritis, psoriatic arthropathy, and connective tissue disease-related arthritis. Okay. Rarely you do have, since TB is indolent in our country, you may want to consider because it can present in various forms. Okay, moving along. Next on distribution and number of joints. So when you look at a patient, they may present to you with just peripheral joint involvement. They may also present with axial, meaning spine, cervical, skull involvement, or you may even have patients that have both at the same time. It's important to determine the distribution because it helps you narrow down what are the possible underlying pathology or etiology. And we listed 3 most common conditions here that affect the hand. So if you can see, let me just put the pointer. Okay, so if you see here, right, areas that are circled in red are extremely common areas of involvement, and yellow is common, but it's involved. So if you have osteoarthritis, you can see first CMC joint involvement, STT joint involvement, and of course DIP joints are very common. The pips are of course involved as well. So if you look at a person with hand OA, if you examine them, they actually have Haberman nodes at the dips, and you have Bouchard nodes at the PIPs. If you look at a patient with rheumatoid arthritis, the distribution usually involves early carpal bone involvement, the MCP joints, and the PIP joints. If you look at a psoriatic patient, generally psoriasis should involve the distal interphalangeal joints. You have PIP joints as well as the STT joints as well. Of course, psoriasis is a bit special. There are various forms. Some may be mimickers of rheumatoid, some may be mimickers of OA. So that you may need to get your rheumatologist on board to see the patient. Yeah. So again, going back to determining between inflammatory, non-inflammatory, here's a simple table. So key differentiating point is pain. Usually inflammatory tends to be more prominent in the morning. They do have some soft tissue swelling. They may be having some redness. Basically cardinal signs of inflammation. Rest makes it worse. They will tell you that Doktor, saya kerja hari ni, bila saya gerak lebih, I feel better. So with movement, it improves. In comparison to mechanical pain, the more they use the joint, the worse it becomes. Okay. If you do have some blood investigations available, there is a tendency of an inflammatory burden in these cases. So the ESR and CRP are raised. But of course, if the patient has taken some NSAIDs, they've taken some steroids, this may not be raised. So you have to take it with a pinch of salt, apply and decide for your patient. If you have a patient that has a large joint, you may be able to aspirate. I think it's very important if you're considering monoarthritis, basically septic arthritis. So you would want to liaise with your orthopedic colleagues. So they will want to look at the white cell count per cubic millimeter. So generally they take a cutoff of 100,000. Okay, but if you look at this table, which is from basically up to date, you do see that even in inflammations, the cells can go from 2,000 up to 100,000. So if it's a pre-existing rheumatoid patient on disease-modifying drugs, I don't think you should take the cutoff of 100,000. 50,000, I think, is a more reasonable amount to consider. You may have to liaise with orthopedic and relay your concerns that even though it didn't hit 100,000, that patient may still have septic arthritis. Okay, but again, a case like this, you perhaps would need to liaise with your rheumatologist for a clearer plan of action. Okay. Moving along, what do you do, or what do you want to examine in a patient with suspected inflammatory arthritis? So this is very variable because there are so many conditions that fall under the umbrella of rheumatoid inflammatory arthritis. So I'll show you some. So this is a patient with rheumatoid arthritis. So we are looking first at the articular features, and maybe we'll look later at some extra articular features. So if you look at this simple diagram, you can see there's some fullness at the MCP joints. Okay, I think it's quite prominent. I'm not sure whether on Zoom whether it's as clear, but you can see some early Z deformities. You've got swan neck deformities, but I think the fullness in the MCP joints is quite easy to pick up. Here, the same thing as well. You have a swan neck and you can see the fullness at the MCP joints. So some early RA patients, they have ulnar deviations of the digits. So that also is something that you may want to keep an eye out. This is a patient with psoriatic arthritis. So you can see psoriasis, they may have a psoriasis rash. They may have nail changes, and you may see changes in the digits, such as the entire digit being swollen. We call that dactylitis. Bear in mind, I think most of us in medical, when we look for psoriasis, we only look for pitted nails. But there is far more than pitted nails for psoriasis. So I've put this diagram, nice diagram down here. You can see there's so many changes. There are nail matrix changes, there's nail bed changes. So by quite common, you do see pitted nails. If you look very carefully, you can find red macules in the lunula. This is called oil spot sign, which is in a nail bed pathology. And very severe psoriasis, you can see hyperkeratosis, crumbly nails, and onycholysis. Okay. A very severe form, deforming arthritis due to psoriasis is called arthritis mutilans. They'll be shortening the limbs, very bizarre looking deformities. Okay, that's one thing to consider, but we try to avoid this happening in our patients. Early recognition of psoriatic arthropathy, early treatment can actually help avoid these kind of things. All right, looking at monoarthritis, if you look at this picture, you can see there's some fullness in the right knee here. So again, you have to look back at the disease onset duration and determine whether it's acute or chronicity. Based on that, you will decide what is or streamline what is your possible etiology. I think if there's a patient with a very nice boggy knee, you may want to actually aspirate, send the fluid for analysis and culture. All right. This is a patient with polyarthritis. On the right here, you can see there's ulnar deviation of the fingers. You can see fullness at the MCP joints. There is some swan neck deformities. There's a nice Z thumb. So this is a patient of rheumatoid. This is a patient with early psoriatic arthritis. You can see some form of dactylitis. You can see some rash here, psoriatic form rash. So these are just some presentations of patients with polyarthritis. So although we have patients with poly, please bear in mind, it's not always rheumatological in nature. You can see many infections actually give us acute polyarthritis. Only when there's chronicity, 6 weeks and longer, maybe you may want to consider rheumatological causes as your main primary differential. Okay, non-inflammatory, there are also non-inflammatory causes. OA, very common. You can have fibromyalgia, you can have hypermobility syndrome. So what I'm trying to stress here is not all of these cases is straight up rheumatological as your primary diagnosis. You have to actually consider a lot of other things first and then consider a rheumatological cause. Okay, moving on. So we looked at the articular manifestations. What are the extra articular manifestations that are present? Okay, this is pretty easy. If you have a patient which has large tophi, you know that the diagnosis is gout. But some of these patients present quite early. The deposition of uric acid is not so prominent, and there may be subtle signs such as tophi in the pinna. So look not only at the hands, you may have to look at other places. All right. This is quite common. I mean, not so common, but if you see it, I think it's quite easy to pick up. So this is a patient with rheumatoid arthritis. This is a rheumatoid nodule. So rheumatoid nodules actually happen on the extensor surface in front of the olecranon process. Okay, but it can also happen in the hands. So this is a patient with rheumatoid nodules in the hands, often mistaken for tophi. Okay, so I just wanted to expose you to some images here so you get some experience on how these patients may present to you. Other extra articular features. So this is looking at patients with psoriasis. So they may present with axial symptoms, spinal inflammatory back pain. They may come with red eyes, which is uveitis. They may have pain at tendon insertion. So this is a patient here where you can see the normal Achilles tendon is on the left, but on the right, it appears thickened. It will be painful. It may be warm. This is a patient where the toes are inflamed and the entire toe is swollen. We call this dactylitis. And down over here, you have a patient that has sebopsoriasis. So you can see a rash that extends beyond the hairline, large plaques. And here over the truncal region, this is, I think, quite straightforward patient with a psoriatic rash. Looking at the nails, like I told you, there are many, many changes, nail bed changes and nail matrix changes. Okay, so these are possible extra-articular features that you can see in your patients. Some more photos. This is another patient. As you can see, this is a normal toe, and the third and fourth toe are swollen. Again, dactylitis. This is another patient, psoriatic arthropathy in the hand. So you can see this is a normal digit of the patient. You have a rash here, a psoriatic rash. There's some nail changes as well, subtle. And you look at this finger, the left third digit is completely swollen. This is a good example of dactylitis, including here, the right second finger is having dactylitis as well. Okay, so you have to look really carefully when you attend to this patient. Okay, this is going towards connective tissue disease related arthritis. So this is a patient of scleroderma. So I'm not sure whether you can make this out, but this patient's skin is relatively shiny. Okay, so they have difficulty extending their fingers because it's so tight. So due to the tight, they've got a lot of joint pain, a lot of pain, stiffness. It's quite a miserable thing. If it's advanced and they have associated Raynaud's, you may actually see digital pit ulcers. They may have digital ulcers as well. Okay, and if you look at this picture here on the right, this is a patient with advanced scleroderma. So you see hypopigmented patches with dots of hyperpigmentation. So this is the classical salt and pepper appearance of a patient with scleroderma. It's a late presentation. You may not see it unless the patient has come very late in the disease. If you have a rheumatological unit or you've been attached to a rheumatology unit and you have a patient with scleroderma or mixed connective tissue, the rheumatologist may do something called a capillaroscopy, and they actually use this device to scan the nails to look at the capillaries. So you have a patient with a normal capillary picture here, and then they have various changes where the capillaries may become enlarged, there may be hemorrhages, and there may be complete structural changes, which we call ramifications. So this you can't see externally, you have to use a specific device. But I just thought I would share that with you. Of course, this is a patient down here with a mala rash. All right. So you moving along, this the last part of the 8 key points which I think you need to address. Find out from the patient whether there's significant history, whether there's anyone with some connective tissue disease in the family, whether there's psoriasis running in the family, whether they have gout running in the family, whether there's any relevant past medical history, drug history. Certain drugs actually worsen certain conditions. So especially very common in gout, thiazide diuretics, Lasix worsen it. So these are important histories that you should be able to pick up. Okay, moving along to investigations. Again, this is dependent on what exactly you're suspecting. So most of the time we do a screening of FBC, RP, LFT, and uric acid if you're thinking of gout, mainly because if we want to start any specific drugs, especially disease-modifying drugs, you need to look at the baseline. Okay, you want to prove burden of inflammation, you should have an ESR CRP. Ferritin, generally we don't send unless you're thinking of adult Still's disease or you're thinking of macrophage activation syndrome or something like that. So generally we don't send ferritin, only in special circumstances. Infectious screening should be done for all these patients because we're starting potent medications. So autoantibodies, it again depends on what you're trying to diagnose. If you think the patient has rheumatoid arthritis, you would send rheumatoid factor, anti-CCP or ACPA. If you think the patient has a connective tissue disease, you may want to send an ANA, double-stranded DNA, C3, C4, and extranuclear ENA. Okay. Bear in mind that you only send this test if you have strong clinical suspicion. These are not screening tests. You don't go randomly and pick people and send this because once it turns out to be positive, but you don't have signs, it does not have any meaning. Okay, so just because the antibody is positive doesn't equate to the patient actually having the disease. There are quite a number of these patients that have the antibodies being positive, but they do not have the disease. It may develop later, but not at that point in time. Okay. If you have a patient which you have a boggy joint and there's a lot of fluid, you may want to aspirate. Gout, the gold standard actually is immunofluorescence. You want to look at crystals, and that is the definitive diagnosis. Imaging, I cannot tell you how important imaging is to us, and I plan to run through some X-rays with you. But imaging, what are the things that we like to order? X-rays, important, ultrasound, MRI. X-rays, unfortunately, when you pick up erosions, it's actually a bit late. Yeah. Ultrasound is way faster. I advocate for ultrasound because ultrasound gives you early recognition and you can decide how quickly to start your treatment. MRI is a bit more harder for us to acquire, but in cases of SPA, ankylosing spondylitis is the most sensitive as it's able to pick up bone marrow edema. And with that, we are able to start treatment quickly. Okay, I'm going to run very quickly through this. What are the different kinds of erosions and where you're going to have to look for it in X-rays. You may want to look in certain areas when you scan a patient as well. So a normal joint, you have two articulating surfaces. It is not a complex joint. Simple joint, two articulating surfaces overlying with cartilage overlying the articular surfaces, and it's kept within the capsule, joint capsule. So a patient with rheumatoid arthritis generally has marginal, I'm talking about early erosions. They start off as a marginal erosions, which is not at the articular surface. It's an area where cartilage is not overlying that part of the bone, but it's still within the capsule. As it becomes more advanced, the actual articular surface will be involved. What about OA? OA usually hits the subchondral areas first, and eventually it will erode even further. There will be joint space reduction, but everything is within the joint capsule. There is a special form of OA, which is called erosive osteoarthritis. So these kind of patients hit quite the central area of the bone, and they have a typical appearance, which we call gull-wing appearance, and I will show you an actual X-ray later on in the presentation. Psoriasis is very aggressive. There's extreme, you can have extreme destruction of the bone surfaces. They will have bony proliferation, but again, within the joint capsule. What about gout? Something we commonly encounter. So we do see juxta-articular erosions. That is basically at the area where the capsule touches the bone. That's where it starts. But of course, if the process is very aggressive, there's a large amount of tophi that will quickly expand into the articular surfaces. So this is just a schematic diagram, probably easier once you see the actual X-rays. So earlier I showed you RA distribution in the hands alone, but bear in mind it does affect the cervical region, large joints, shoulder, elbows, hips, and knees. In the foot, again, mid-tarsal, similar to the carpal in the hand, the MTP joints and the PIP joints. Erosive RA generally hits only the hands. It's different from OA. OA you can have knee OA and hip OA as well as those in the hands. But erosive RA seems to be a bit more exclusively in the hand. Okay. All right, let's move on to some X-rays. I wanted to actually ask people some questions, but never mind. Since I can't see the crowd, I will probably answer these questions myself. So these are two different patients, okay? So this is a terrible X-ray because the radiographer did not remove the ring, okay? But if you look at it, this particular X-ray, eyeballing, you don't see anything spectacular. It looks pretty normal actually. You assess first, if you're thinking of inflammatory arthritis, look at the carpal bone first. So you can see the carpal bone space is not really badly affected. The bone itself looks pretty nice. You don't see any erosions at the MCPs, PIPs or DIPs, but if you actually zoom in, you can see there is some periarticular osteopenia, which is not easily seen here, but it is present. So one of the earliest X-ray changes that you can see is periarticular osteopenia in a case of rheumatoid arthritis. Another early change is you see what we call as carpal crowding. So the carpal bones tend to start to get crowded closer to each other. That these two changes comes way earlier than erosive changes. So erosive changes are late, okay, for an X-ray. Same here. So this one is a bit more easier to appreciate. Okay, so if you look at this patient, this is how the bone density should be, but you can see here there is some early changes, and especially around the MCP joints, you see periarticular osteopenia. So this is two cases are examples of early RA patients. Yeah, the patients presenting with early rheumatoid arthritis. Okay, this is a nice one. This is two different patients, but I want to show you two different pathologies. So this is an X-ray of the knees. So if you look at this knee, right, this is the medial joint space, and this is the lateral joint space. So when you look at it, you can see here some sclerosis already going on here. There is medial joint space reduction, and there's some osteophytes here. So if I didn't have any history and I'm just looking at this particular X-ray, I would be looking and saying that this is probably an osteoarthritis of the knee. Okay, you can, but on this X-ray on my right, now here, if the patient, if I'm just looking at the X-ray, I don't have much history, what I think strikes me odd is there is a complete reduction in joint space. Not, if you can see, the total joint space has reduced. It is on not only on the medial aspect, it's also on the lateral aspect. So this would be, in my opinion, someone that may have some form of inflammatory arthritis. So you have to pair this with a good history and an examination. Okay, a little bit more. Again, this was supposed to be questions for you all to answer. So these are marginal erosions. Okay, you can see it in, I might as well just show you the answers. So these are marginal erosions. Okay, it's not at the articular surfaces. Okay, this is a patient which I told you has erosive RA with a typical seagull appearance, central erosion. This is gout. Okay, some people use the description of a punched out erosion or rat bite erosion. Okay, over here, this is a very bizarre looking morphology, tends to happen in a patient with septic arthritis, and you can see there's a lot of soft tissue swelling here. All right. This is a patient with psoriatic arthritis, a very advanced version. Maybe some of you would have heard pencil in a cup. So this is called candy lick sign. The cup hasn't fully formed. As you can see here, the terminal phalanx hasn't actually eroded inwards, but the bottom part is become sharp. So the description of candy lick is for people in the Western world who celebrate Christmas. They have a candy cane and they suck on it and it becomes sharp. So that is the other description for psoriasis, a candy lick sign. Or if this progresses further, it will be known as pencil in the cup. This is very rare. The last picture here is acro-osteolysis in a patient with scleroderma. They have shortenings of the terminal phalanx. Okay, all right. Some more pictures just to show you. Again, this is a patient with osteoarthritis. You can see here I've zoomed in. So I think this is a very nice picture showing you a seagull sign. All right, so you can see central erosion. It looks like the wings of a seagull. Okay, and it's very prominent in all of the distal interphalangeal joints. The PIPs you can see are relatively preserved. Okay, so this is a case of erosive OA. Erosive OA, bear in mind, they tend to have a normal CRP, ESR. Why? Because the focal inflammation is at the joint itself and it doesn't spill into the systemic systemic part of the body, unlike other inflammatory OAs. Okay. All right, this one is a patient with rheumatoid arthritis. Okay, why do I say so? Again, whenever I look at X-rays, I tend to jump straight to the carpal bones. So this is quite an advanced case. You can see here there's basically carpal bone fusion. You can't really make out the individual carpal bones. There is some periarticular osteopenia. The MCPs are slightly subluxated, so it looks like it's overlapping, right? There is PIP involvement as well. To be honest, I think there's some amount of secondary OA as well, especially the DIPs here. So OA does come in with our patients because when you have inflammatory arthritis, there is wear and tear of the joints becomes accelerated. So a lot of them also do develop secondary OA. But this patient's primary pathology is rheumatoid arthritis. Okay. All right. A little bit about classification criteria. So I'm not going to go into the details of this. There's too many things for me to cover. What I urge you to do is go on your Play Store if you use an Android phone, or if you have an Apple iPhone, go to your Apple Store, download this Ruma Helper. So it has a lot of the classification criteria there. Yeah, RA, you have the 2010 ACL EULA. You have so many things there. Not only do you have the criteria for classification, you also have the scoring for diseases where we want to achieve a treat to target level. You are able to key in the information there and it will tell you whether the patient's disease is active, whether it's moderately active, or the patient's in low disease or remission. It helps guide how we treat the patient. Remember that classification criteria does not mean, oh, I do not fulfill this, means that the diagnosis is out of sight, out of mind. No. If it fulfills, great. If it does not, then you have to look at the patient holistically. All right. Okay. Okay, what about diagnosis? So the diagnosis basically is based on clinical findings supported by your laboratory tests, your imaging tests. Okay, like I mentioned just now, classification criteria is not a diagnostic criteria, although gout has an Oxford diagnostic criteria. But for the others, it's basically just classification. It was used mainly in research, but it does aid us when we see patients in real life. Okay. And autoantibodies without a clinical presentation does not have much of a meaning as it's not diagnostic. How do we manage our patients? We need to identify them early and treat them. We have certain targets to achieve. Different conditions have different scoring systems, and we try to tailor and adjust medications to achieve remission and low disease activity in our patients. How do we treat our patients? Again, this is a difficult thing for me to pass on to you all because different conditions have different modes of therapy. But I suppose at the level of a physician, you can start initial treatment, but eventually the treatment has to be passed over to the rheumatologist to optimize. Okay. Bear in mind, we are a very team player. We need physiotherapists, we need occupational therapists, we have special nurses to help us. So we work together and often we co-manage patients with other disciplines. For example, SLE patient, we may need help from the nephrologist. If we have a patient who has SPA, we may need an orthopedics involved. So we are very multidisciplinary, we are friendly with everybody. Okay, very important. Most of our patients need to be educated all the time. When your patient understands what they are going through, they are going to listen to you. If you do not educate your patient and you expect them to follow you and be compliant to your treatment, it's going to be difficult. Okay, and always involve your patient. It's always a shared decision making. When you make a decision together, outcomes are always better. Okay, so this is a large overview of what are the treatments available. So generally we use drugs called disease modifying agents. There's so many versions of it now. There's so much in the market. You've got synthetic, targeted, non-targeted, and of course we have the BMW of medications, the biologics now. And thankfully now in Malaysia, we have something called biosimilars, which are a bit more affordable, but give you the same amount of effect as the original biologics, okay? So aside from all the medications that are available, the non-medical options include therapeutic exercises. It involves dietary and nutritional advice, and there's also complementary therapy. In cases where the patients come in late and they're burnout, we do help them sometimes with pain therapy. There's some rheumatologists that do something called PIT therapy, and PIT therapy actually helps patients, chronic patients with a lot of pain, manage their life better. Okay, so I'm going to end this session with a quick case. I don't know whether you guys can actually type in, but anyway, this is a 56-year-old lady that presented with pain and swelling in her fingers for the past 6 months. The pains were episodic. There was some cardinal signs of inflammation. There was redness, there was swelling, there was some stiffness. The stiffness was very bad. Once it happened in the morning, it was there, extending throughout the day. She had difficulty even opening some of her jars, couldn't grip very well. Okay, and the stiffness was there for about half an hour. There was nothing else in the history that was helpful. Yeah. So when she was examined, she had tenderness and swelling at the bilateral in both her hands, the DIP and PIP joints, and a very prominent one was the right index DIP. Didn't seem like her wrists or the MCP joints are involved. The medical officer that saw this patient felt there were Haberden nodes. He looked very hard for psoriatic skin lesions. For nail changes, none were present. And the ESR and CRP was normal. Okay. They organized a rheumatoid factor and ACPA, and it was found to be negative. So this is supposed to be interactive. So I was about to ask you all what are the features that point against RA here, and what were features that point against PSA. So if you look back at the patient here, if you look at it, so you see, as I told you, look at distribution. If you're thinking RA, you would expect more of a MCP PIP involvement. The fact that DIP is involved in this patient is a bit weird. If the patient was not taking steroids or constant NSAIDs, you would expect ESR CRPs to be a bit higher rather than normal. Okay, so those were features against RA here. The fact there's Haberden nodes, which is more common in OA, is another point. But of course, like I told you, secondary OA can be there in rheumatological conditions. Against PSA, right? Oh, okay, and RF anti-CCP is negative lah. So RA is a bit odd. Okay, so sounds more like a seronegative here. But again, the inflammatory marker is normal. You don't have any skin changes, nail changes. But bear in mind, 1/3 of psoriasis patients present with joint manifestation first, without any skin, without any nail changes. Probably about 10 years later, those may crop up. Okay. All right. Now, looking at the X-ray of this patient, I hope that you were listening earlier and you will be able to make this out. So again, how I approach the patient is, again, I look at, this is a X-ray of, this is an AP joint, okay? No, actually, this is a ball catching view. So we do a ball catching view, basically to open up the MCP joints to look for more erosions, okay? So if you look here at the carpal joint looks fairly preserved. There's good space among among the carpal bones, okay, and looking at the bone density of it looks all preserved, looks very nice and white. I don't see any periarticular osteopenia, so I do not see any erosions at the MCP joints. Quite safely, I would say this is not a patient with rheumatoid arthritis. Now, as we climb up, we go up. I think if you were listening earlier and were able to follow along, you can quite clearly see that this patient has extensive seagull appearance of the pips. Okay, and even the distal DIP joints, there are some they do not have the seagull, but you can see there's bony fusion here as well. So I would say that this patient has erosive OA. All right, same patient. Now she was complaining of knee pain. Okay, now I don't know whether you can appreciate this. Okay, but there is a slight reduction in a joint space in the medial aspect. There's some osteophytes, but look here in the joint space here, there is calcification of the cartilage, and you get this in chondrocalcinosis. Okay, and that comes with elderly patients, patients which with OA. Okay, so this is basically pseudo-gout. Aspiration was done, and there were CPPD crystals. Okay, so that's a very, very simple case. Okay, just a case of osteoarthritis. So to summarize the talk for today, recognize key inflammatory arthritis features, what I told you right from the start of our of this webinar. Try to apply a stepwise approach, very systematic approach, good history, good targeted examination, look at your laboratory testing, look at your relevant imaging, and then come up to a conclusion. See what needs to be identified and sent to the rheumatologist quickly. That means urgent cases, and start treatment promptly to prevent irreversible joint damage. So with that, thank you very much. Yeah, if there are any questions, you may put it in the chat or ask. Thank you.
Okay, thank you, Pradeep, for the very comprehensive talk on the approach to joint pain. I think many of us really do not like when patient actually comes in and says, "Oh, I've got pain in my joint, doctor. Pain in everywhere is actually paining," they said. Okay, so anyhow, there's one question here. Is there any difference between highly sensitive CRP and CRP? Which one that would you prefer?
Okay. Yeah, good question. Thanks. Thank you very much. Okay, if you look at HSCRP, right, you need to understand that why was HSCRP actually created? It was not used for joint involvement. It's basically created to pick up cardiovascular risk. So if you look at the interpretation of HSCRP, it is more in terms of severe risk, and these are the patients that they decide that they need perhaps to escalate investigations towards the heart. So I personally do not use HSCRP because for looking at inflammatory burden in terms of the joint, because I think it's way too sensitive. So you may be unnecessarily investigating the patient. I don't know whether Dr. Noraini agrees with me on that.
Yeah, I think in order for us to actually get the CRP also, it's not very easy because do ESR and CRP every time. I think that would actually cost a lot of financial burden to our lab. So I think yeah, again, I do agree with Pradeep that HSCRP is mainly to look at the micro inflammation, particularly looking at the CV risks. I think they talk about HSCRP when they are actually looking at the different statin and how the statin actually works in in the reduction of CV risks. I think in terms of joint, CRP alone is okay.
Yeah. Any other questions? Burning questions?
Any other question? I think
Either they all slept off from the top.
either the talk is very clear, they've understood everything. Okay, let me put this question to you. Majority of the time, people are very relying on the laboratory test.
Yeah.
Do you think you really need the rheumatoid factor or even the ACPA in order to make a diagnosis of rheumatoid arthritis?
No, I personally don't think so. I think with a good history and a good examination, especially if the patient comes with quite, I mean, if they come at a point where you can pick up some signs in them. But having said so, I perhaps have a cheat because I tend to scan a lot of my patients, and having an ultrasound, I think, helps a lot way before that you using an X-ray. And I think if you have a good history, a good examination, and perhaps the help of an ultrasound, if it's rheumatoid arthritis, you probably can pick up way before. Having an ESR CRP definitely helps. At least it proves the burden of inflammation. But specifically for a rheumatoid factor and anti-CCP, I perhaps may not need it to make the diagnosis. You can use the classification criteria to help as well.
Yeah.
So yeah,
I think what you have to understand between the ACR 1987 and the 2010 ACR and EULA criteria, it's just to add on points for you to put, I mean, to see whether this is erring towards rheumatoid arthritis or whether it's actually some other form of inflammatory arthritis. But one thing, it shouldn't stop you from initiating treatment. And at the same time, the most important part of the ACR EULA 2010 criteria is that you can add on when you see the patient in the next visit, if there is additional points for you to add on to the previous points.
yeah. So Priscilla we don't seem to have any more questions.
Yeah. Yeah.
Anybody else? So we still have about 8 minutes to go.
I think I put them to sleep.
Okay. In
Oh,
KPM level, for multiple small joints tenderness, if RF is negative, ESR normal, anything else do we need to investigate before referral?
I think okay, Sasi, right? Sasi, I think it again boils down whether, okay, when you say referral here, I assume you want to refer to the rheumatologist, right? So you just have to perhaps decide whether first it's inflammatory or not. If you're able to determine it's an inflammatory arthritis, I think what you've done here, RF negative, ESR is normal. You've done X-rays. There's no harm referring the patient as possible seronegative arthritis and leave it to the rheumatologist to work it out. But if from day one your patient doesn't have inflammatory arthritis and rather mechanical, then I think the referral should be towards an orthopod instead.
I think to add on to that, the most important aspect is actually again, as what Dr. Pradeep has mentioned, whether it's actually inflammatory or degenerative. So you have to divide into inflammatory or degenerative, whether you are really convinced that that is actually inflammatory in nature. Okay, even in degenerative also, they can also have early morning stiffness for about 30 minutes. And then after that, you determine which part of the joints which are involved. Okay, so typical joints for RA, you have to know typical joints for typical joints involvement for PSA and OA also you have to know, including gout. Okay, so the joints involved, early morning stiffness, exacerbating factor, and all this will probably point towards whether you really have some form of inflammatory arthritis. So if your ESR and CRP are normal, you really have to think hard to actually say that this is definitely, I mean, you have to refer to the rheumatologist. I think one of the things that you can consider to check on is probably vitamin D. What do you think, Pradeep?
Yeah, agree. A lot of our patients, so basically, I think the Malaysian population, a lot of us are actually having very low levels of vitamin D, mainly because all of us do not like to go out in the sun. I think for ladies also, nowadays, most of the makeups or even the sunblocks, the SPF is quite high, and that actually prevents vitamin D absorption. And vitamin D absorption has been associated also with joint pain and tenderness. So it's definitely something we need to look into. Is there any other questions? We have another 4 minutes.
There's another question here from the Q&A box. If fulfill diagnostic criteria for RA, will you mind share how will you treat the patient with demands? Can we treat in primary care or GP?
Well, I don't think in primary, okay, when you start DMATs, I don't think you have DMATs in the clinic kesihatan, as far as I know. So DMARDs, I think there's multitude or multiple kinds of drugs out there. But if you're talking about rheumatoid arthritis specifically, I think an anchor drug or usually what we usually would start will be methotrexate. So there are a lot of things to consider. Before starting, you have to make sure the patient has had a proper infective screening. They need to be counseled because most of these patients tend to be ladies. And if they are in a reproductive age group, you must be aware that methotrexate is has is not safe in pregnancy. So there is a lot of discussions that need to be done. So I would think that what would be more prudent for you to do at a clinic kesihatan level would be to start the patient on a good anti-inflammatory NSAIDs if there are no contraindications to it, and get the patient to be seen by at least a medical specialist physician or the rheumatologist direct if the unit is available near to your clinic kesihatan setting. I do not think that methotrexate should be started at the primary healthcare level. I hope that answers your question.
I think the CPG that we have launched on in terms of RA and gout and lupus, we do want to empower our primary care doctors to actually be able to pick up potential inflammatory arthritis patients, potential lupus patient, and also to treat gout accordingly. So I think as far as I am aware of at this point in time, we are trying I mean, we have already managed to push gout, uncomplicated gout, to be treated at primary care level. We would like to get hydroxychloroquine at least to be able to be started by the physicians in primary care. That's the reason, the whole point of having the CPG SLE. But in terms of DMARDs in primary care, maybe it's a bit too early. Okay, for us, because we also need to empower our own physicians, general physicians, and our medical officers in terms of how to use the methotrexate and what needs to be discussed when you suddenly decided to put a patient on methotrexate. Yes, of course, it is an anchor drug, but there's a lot more to all this. You have to you have to undergo a proper training in terms of wanting to use all this complex medication. But at least at your level, you can, apart from NSAIDs, you can even start a low dose prednisolone, yeah, about 10 milligram daily. After consulting any one of us, also your family medicine physician. Okay, so I'm quite happy to, I mean, if on my side, sometimes what I tend to do, if they think that the patient has got RA, I ask them to actually send, usually when I ask you to send a photo of the hands, okay, maybe because when I see ESR, CRP are normal, and I don't quite believe the swelling that you described. Okay, sometimes the swelling that you described is actually evidence, not evidence, a Beauchart's, which is a bony swelling. Okay, and I've had referrals before where they think there's synovial swelling. When they give the photos to me, it is clearly nodal hand OA. So we do not want patients to be simply started on methotrexate also unnecessarily when the diagnosis is not quite RA. So,
So are we any last questions?
last question. Maybe last question for Dr. Pradeep.
Anyway, I hope the session was useful and you all managed to learn something and perhaps help you with your referrals to your, if you're in primary care, referrals to your nearest tertiary center. I mean, it's really nice to hear that some of you are very gung-ho about starting DMARDs and trying to institute what's best for the patient. But I think as Dr. Noraini has said, I think early recognition and getting your patient over as soon as possible to a tertiary center would be the best at this point in time. So Priscilla, should we end the session?
Yeah, thank you, Dr. Pradeep, for the concise and precise presentation. And also thank you to Dr. Noraini to explain about your experience in managing approach to joint pain. Thank you, Dr. Pradeep and Dr. Noraini.
Okay,
Okay,
bye-bye.
bye.